Digital transformation impacts quality, but its jargon can be overwhelming. I'm Andy Reynolds. On this episode of Quality Matters, NCQA Chief Technology Officer Ed Yurcisin and I continue our tour of tech-based initiatives that are critical to quality's future. Listen to our previous episode, number 18, for Ed's relatable explanations of digital HEDIS measurement and fast healthcare interoperability resources, or FHIR. In this episode, we discuss new topics. Ed uses metaphors and analogies that cut through jargon and make technical topics clear. We end by talking about Ed's unusual background and how that relates to his desire to help improve healthcare. Here is my ongoing, illuminating conversation with Ed Yurcisin. Ed, a big lesson I took from our earlier conversation is the importance of data quality. Here's what you said.
Nothing in digital transformation in healthcare makes sense without high-quality data exchange. It's foundational. The digital transformation of healthcare is necessary to deliver higher quality care, but that is completely dependent on high-quality data and the ability to exchange data.
You also explained the Data Interoperability Standard, FHIR, or Fast Healthcare Interoperability Resources, and you described how the NCQA Bulk FHIR Data Quality Coalition is testing the exchange of population-level quality data.
The Bulk FHIR Quality Coalition is one of the NCQA efforts to drive data quality. It's use case specific, and the use case we're utilizing is HEDIS, quality measurement. We're working with health plans and insurance companies that exchange data to understand the quality of the data.
I understand that testing population-level data exchange for HEDIS quality reporting has benefits beyond quality reporting. Can you explain what those are?
I've been using the snowplow analogy, which is NCQA can be used as the snowplow for data quality. What I mean is we're in a unique position at NCQA. Our HEDIS measures are incorporated into government payment programs. For example, Medicare star ratings. That means it's connected to money. There's incentive to enable digital HEDIS because it is tied to your CMS star ratings and the amount of money a Medicare Advantage plan might receive from the government. That's not the case for other important use cases, whether it be public health or prior authorization. So our infrastructure is tied to financial returns, incenting organizations to make higher quality data accessible for digital HEDIS. And that means if it's good enough for digital HEDIS, it's been cleansed and analyzed in a way that could be used for public health, that could be used for prior authorization, all of these different use cases.
Ed, you sound like Frank Sinatra singing New York, New York. If you can make it there, you can make it anywhere. If data is good enough for digital HEDIS, it's good enough for other things, right?
Absolutely.
I want to make sure I understand everything that you intend with your snowplow metaphor. To me, a snowplow pushes an obstacle out of the way. But is that really what you mean with population-level data exchange?
I wouldn't think about it as pushing. It's really establishing a path to go to different places. We're plowing the road in order to go to work. Well, we plowed the road, so now you can go to the grocery store, the shopping center. Now you can go to these other places. We're clearing the road for our use case, which is quality measurement. But because we clear the road, it's available for these other use cases.
In our last conversation, you explained that digital HEDIS means measures are written as clinical quality language, or CQL. People may have heard of software called SQL, sometimes pronounced SQL, but also SQL. Can you tease apart for us SQL versus CQL? What should we be hearing?
So SQL, often pronounced as SQL, is the language used to access relational databases. I'm sure you will use it today behind the scenes as you go to a web page. It is running queries to any relational database. The industry has been investing in this for decades. Clinical quality language is newer. It's implemented through HL7, one of the standards organizations, to create a language where you can express logic that a clinician could read.
Okay, so CQL, clinical quality language, is made to be comprehensible to both computers and to people. But it's not the same as SQL or SQL, which is more common and not specific to healthcare. Correct?
Yes, absolutely.
Let me have you tease apart two other metaphors. First, what is a HEDIS engine? What is a CQL calculator? And what's the relationship between those?
That's a great question. And there's a lot of confusion over what is the engine. In automotive terms, is it just your 8-cylinder engine, or does it also incorporate your fuel pump and the whole gas infrastructure? The term HEDIS engine, for me, that's an organization's entire technology stack and data platform for calculating HEDIS that incorporates databases to store the data, to extract the data, all the way to where do you store the results.
Okay, so that's the engine. How does the idea of a calculator factor into that?
From an enterprise standpoint, a lot of things need to go into your platform. A lot of data manipulation, putting data into the right format. Say you are an insurance company. You're receiving new data from your provider partners or from the hospitals daily or weekly. It is your job to figure out the cloud or technology infrastructure to run this. That's not what NCQA does. Our job is not to create the technology stack for running this. We are not a technology company. And this is the chief technology officer saying this. That's not a decision we make at NCQA. We've made it generic and open, enabling you to make these technology decisions. Because these decisions can vary based on what you're trying to solve and your particular situation.
I want to come back to something you said there, but let's recap. You were saying that the larger metaphor of a measure engine involves many decisions and processes that are outside or upstream from NCQA. But you also have this idea of a CQL engine or a CQL calculator within that larger process. And that smaller piece is a place where NCQA has gotten involved. Tell me about that smaller piece, please.
Yeah. In between, there is a very specific calculator or CQL engine. The CQL engine we've developed, or a calculator, is one critical component of this process. You're trying to learn about your patients, trying to do some math. Our measures at NCQA are fairly complex, and more complex math requires a more sophisticated calculator. The calculator, it's critical because we need all 80 digital HEDIS measures to be calculated correctly. There are some basic calculators that have just addition, subtraction, multiplication, and division. We're adding more complex mathematical functions, and we need calculators to incorporate those functions. Additionally, remember back to algebra, order of operations is critical. If you remember, they put parentheses and you would do addition before or after multiplication. These are concepts that require industry alignment and standardization. We have open sourced the engine that was developed at NCQA with others. That's been made available. And that's just one component to this process.
Can you give me an example of how this larger engine process comes together?
We have a measure called breast cancer screening. Does your HEDIS engine select women of a certain age? You don't need to screen infants for breast cancer. So how do you select the proper population for this? We have measures for pediatric care. Your HEDIS engine should be screening out everybody that's not in that pediatric age range. And that makes your whole calculation more efficient. The CQL engine we've developed, or a calculator, is one critical component of this process.
A moment ago, you went out of your way to emphasize that NCQA is not a technology firm. I'm curious, why did you feel that was important to say, and what's the benefit to the wider world that NCQA does not aspire to be a tech firm?
That's an important position because we didn't create this CQL engine to compete with other engines. We are not trying to compete on the efficiency of a technology platform or a technology stack. There are different technology stacks out there, and our focus as a company is on the content. We are driving content and we need to ensure measures are calculated correctly. We've developed this technology to ensure, for example, the breast cancer screening measure is being properly calculated. We can certify different implementations and make it less burdensome and more efficient to ensure everybody's implementation of breast cancer screening is working the same way. Our core competency, still using the breast cancer screening measure, is to create a measure that is able to identify care gaps or opportunities to improve care. NCQA is sticking to its core competency and our mission, which is to improve quality.
So NCQA has helped create a CQL engine or CQL calculator. It's open source, meaning that anyone can use it or even modify it. I understand your team is also involved with something called the Digital Quality Implementers Community, which is essentially harmonizing different CQL engines. What can you tell me about that?
It's not our program that we're running, but NCQA is influential in this. Our DQIC, or Digital Quality Implementers Community, is aligning engines, ensuring engines are all doing basic things like order of operations to ensure calculators operate the same way and have the same level of functionality. It's kind of crazy when you think about it, but you need an industry-wide effort to ensure everyone is doing the same math. So that's been our purpose for DQIC, to really advance engine capabilities and align the use of CQL.
To learn more about the Digital Quality Implementers Community, I went to NCQA's point person for that project.
I'm Amol Vyas, Vice President of Interoperability at NCQA.
Why is the Digital Quality Implementers Community necessary? Or what problem is that group trying to solve?
The behavior of SQL engines that exist in the ecosystem varies widely. If you have seen a SQL engine, you've exactly seen one SQL engine. So the community started by saying, hey, let's look at maturing the SQL specification and bring the SQL engines to a maturity level where they run HEDIS measures in a consistent, unambiguous, and standards-based way. The DQIC, or the Digital Quality Implementers Community, was formed with that focus. It's not trying to boil the ocean, trying to have SQL engines run every possible measure. We're starting with HEDIS digital measures to see if SQL engines can run the mature HEDIS specification in a predictable way. This is aligned with the CMS roadmap and federal agencies push for more standardization. The idea is to produce consistent results. So you have choice and confidence in calculators in the market.
Tell me more about choice and confidence.
The idea behind is to ensure choice and confidence in the implementations out there. We mature the specification, but also help the implementer community introduce choice and confidence as far as SQL engines in the market. I, as a user, am free to choose any SQL engine. I'll have a choice of engines when it comes to running HEDIS measures. The idea is to position the SQL specification so it can standardize not just HEDIS measures, but also non-HEDIS like ECQMs. And confidence is the confidence that the capability I will use once I make that choice is going to be consistent across products or implementations. This allows the vendor to offer choice and confidence to their customers in being able to run or translate SQL in a standards-based way.
Who's in the community? Who can join?
If you are an organization that is either working on a SQL engine or maintaining a SQL engine, I think this community is for you. It is a public-private partnership where we involve not just SQL implementers, but also SQL specification authors and subject matter experts, federal agencies, our observers. We have CMS. We have ONC, Office of National Coordinator, now called Assistant Secretary for Technology Policy. The idea is to align with the federal interoperability agenda.
Amal, I've heard you compare the DQIC or the DQIC to a 3-layer cake. Walk me through that, please. What is the first level of this 3-layer cake?
The layer cake consists of the data layer at the bottom. The data layer is about the fuel. This fuel needs to be standardized and transported in a consistent manner. That standard is FHIR, Fast Healthcare Interoperability Resources.
Okay, so fire in the belly or fire at the base to fuel everything. The second of 3 layers, the one in the middle, is called enablement. What's happening in that middle step?
The middle layer, also known as clinical reasoning or infrastructure, is the focus of digital quality implementers community. We're talking about the engines here depend on the fuel, which is the layer below. The CQL engines consume the fuel and produce consistent output. Basically, DQIC plugs into that to rally an ecosystem that focuses on standardizing the middle infrastructure layer to enable applications.
Okay. And how should we think about the top layer, the application or content layer?
So the top layer or the application layer is where you see the use cases that the market demands. Produce consistent, unambiguous results, whether those use cases are HEDIS reporting or care gaps or performance reporting. But all of those applications depend on the enabling layers under it. Therefore, the layer cake is essentially how standards fuel the innovation in quality applications.
So 3 layers. At the bottom or the foundation is data. The middle layer is the enablement layer, where one finds the CQL engines that the digital quality implementer community is focusing on. And then the top is the content or application layer, where people have apps and quality assessment tools. That's where the rubber meets the road and the underlying math becomes real in the world. Is that a fair summary?
Yep, that's right. Another thing NCQA is doing to help implementers is we have provided a test code for our HEDIS measures to start with to implementers to test their implementations that will help the implementers validate that they are running these HEDIS measures correctly. I call it the bottom-up method of verifying that the implementation is consistently running HEDIS measures. And we will look at making more test code available. Depending on where the implementers are, I think we're going to get acceleration in HEDIS being supported by the implementation community.
Thanks, Amal. We will link in the show notes to the Digital Quality Implementers community so that organizations that have CQL engines or are interested in CQL engines can get involved.
Thank you.
Okay, Ed, let's give you the last word. I'm curious about your perspective and your motivation in all this. I remember when you first came to NCQA 3 years ago, you introduced yourself at an all-hands meeting, and you spent some time talking about your family's roots in Mexico and the fact that you, your wife, and your kids had moved back to the U.S. from Mexico not too long earlier. I'm curious, how do you think that international perspective changes what you notice about American healthcare, and how might that affect how you see your work?
Having an international perspective opens your eyes to challenges in the U.S. healthcare. People tend to travel more within the country. People tend to move more frequently. And that means you're changing providers. And when you simply go on vacation, being able to access your medical records could be life-saving.
For Ed, the need for data interoperability cuts close to home.
We now live in Washington, D.C. And if we're on vacation in Florida and my wife gets sick, I need to have access to her medical records to know what she is and isn't allergic to, what medication she might be on. But when you start dealing with somebody like my mother, who happens to live in Seattle, Washington, it becomes very challenging because she knows she takes the blue pill every morning. But what is the blue pill? And, did they change? Is it 50 milligrams or 100 milligrams? A typical Medicare Advantage beneficiary goes to over 6 different care providers. But the challenge when I speak with my mother is, I went to the doctor this week. Well, Mom, which one? You have 8. But does that doctor have a full understanding of what the other doctors are doing to help my mom with her chronic conditions? My mother came to visit us, and we needed to have an understanding of her medical records. We were fortunate because my brother had access to this data. If data wasn't interoperable, it would have been very challenging. And that's how you have medical errors, you have misdiagnosis, or it just simply takes longer to get to the proper conclusion.
That sounds like a reminder close to home of why data interoperability matters.
Yes, absolutely.
I think that's a good place to end. Ed Yurcisin, Chief Technology Officer at NCQA, thanks for being part of Quality Matters.
Thank you, Andy. It's great to see you.
Look in the show notes for links to the Bulk FHIR Quality Coalition, the Digital Quality Implementers Community, and other resources that can help you navigate the digital quality transition. To learn about data-driven strategies and practical solutions for addressing health disparities in underserved communities, attend NCQA's Health Quality Forum, April 7th and 8th in Baltimore. Topics include virtual care, rural access, health equity, and maternal health. Register at ncqaforum.org. Thank you for listening to Quality Matters. If you enjoyed this episode, please rate this episode 5 stars. We'll see you next time.